an amazing institution. I owe a great deal of gratitude here, and to many people, you know, certainly Joe Greenfield. Where are you, Joe? Where'd you go? There you are. And Galen. Gus, we never worked together, but you were a source of calm, decency, kindness, helped put salve on my back to heal the scars. Current residents and fellows, you don't have a clue. Doug, did you ever work with John?
Yes.
Yeah.
And have some of those scars as well.
Yeah, well, mine are about that thick and deep. So whenever you complain about some attending not being good to you or whatever, just zip it. You have no idea. But he was brilliant and a great teacher, and we learned a lot. The whole problem of Wolff-Parkinson-White syndrome, AV node reentry, pretty much solved single-handedly by him. So great guy. I also, of course, I knew Carrie only as this vague mathematical guy when I was here, but since have had a lovely long-term academic, beautiful, warm friendship for 20-some years now, working on various clinical trials that DCRI has organized and been the main workhorse behind ideas that seemed whimsical at the time. So I'm going to chat a little bit about some of the things that led up to the subcutaneous ICD, give you a little bit of rationale. Please feel free to interrupt and just fire off at will questions. I don't mind that at all. I was well trained here for that. So disclosures, Cameron Health is the company that I started. It's named after my son, Cameron. And so I'm conflicted up the yin-yang, okay? And a few other things. So this is what we're going to talk about. I don't know how many people are aware of it. We'll give you some background to it. It's purely subcutaneous. And this is kind of what it would look like if you had see-through vision, and just sits on the rib cage. And we'll chat about its development and where it's useful. So let me start with some general theme of why the sub-Q space. Lead advisories, notice the dates, right? You're all thinking, all the arrhythmia people here are thinking Fidelis lead, Dorada, Reata leads. Those are recent. But this problem is persistent, has been going on forever. Trying to build leads that live in that incredibly hostile environment, moving 60, 80 times a minute for decades, it's an impossible task. The engineers really work hard trying to make leads last, but they break. So these are old data, no different than today, and it will not change. Failure rates, well known, leads fail. In fact, when I put in an ICD on a patient, I tell them that their leads will fail. I don't say they might fail, I say they will fail, it's a matter of when. Failure rates conservatively 25% over a few years. So let's go back to the SICD history. Just an idea of how long it takes to do something in the United States. So the idea came into my head in 1994. Now I'll give you a background on why. FDA approval this past September, plus a mere $350 million. Okay, so it didn't happen right away. So at the time, I was working on the development of the automatic external defibrillator, with which we did the home AED trial here with Carrie. So I was developing algorithms and waveforms with a small company that got involved with in Seattle called HeartStream. A small device, but in that process, because I was doing ICD work, I was also doing transthoracic defib work, I was able to get down on the skin to defibrillation energies of 115 joules reliably. And that made me think, gee, maybe that, with the fact that I lost a young woman to a non-thoracotomy lead fracture in the days of the big non-thoracotomy leads at the rib margin. She died of a cardiac arrest, multiple shocks, wasn't rescued. Post-mortem x-ray showed the lead fracture here at the rib margin. That event, plus my work on AEDs, made me think, yeah, this might be possible. I ruminated and ruminated and ruminated for 6 years until one day I was chatting with an entrepreneur, venture capitalist guy, and I mentioned the idea and mentioned this kind of vision of what was at that time called a unipolar or leadless, truly leadless ICD. And within a week we had $5 million to start a company. Not personal money, but company money. And we started out with this idea, and we started out with various envisionments of how we might put hardware under the skin and put electrodes that were encased under this, have all the engineering in here. It was very stylish, kind of futuristic designs, but impossible to build. Putting electronics in curved spaces is not easy and very difficult. So over the years, we did, I'm just going to show you a mosaic only to show you that what you see as the FDA approved product was built on the back of a lot of hard work, mostly on the engineering side by a guy up in the back, John Hunt. But these are animal studies, pigs, dogs, sheep, over 10 years. We started in September of 2000. Lots of animal studies looking at different leads, different shock configurations, waveforms, detection algorithms, and equally a large number of human studies. And another Dookie was involved. We finally, after 8 years, did the first human implant with Warren Smith in Auckland, New Zealand. Warren Smith, like me, was a Ray Idaker Fellow and a John Gallagher Fellow. And Warren, a wonderful man, wonderful physician, had a beautiful lab in New Zealand. And when we started this, you can imagine paranoia, because this is the kind of device that could destroy big corporations that make a lot of money from ICDs. We hid in Auckland, New Zealand. I got a medical license in Auckland, New Zealand. I was down there several times a month, and we did our research and development down there in this tiny little space with Warren Smith and Margaret Hood, who was the actual physician. But we did a lot of background work, described this briefly in the New England Journal paper. But the most remarkable thing for the dermatologists in this room, the most remarkable thing was this very first patient. Our engineering group at the time, we just kludged everything together, at a hardware store. Got disc electrodes, stainless steel, sterilized them. And I'm doing this procedure not knowing what we're going to find. Shoveled these plate electrodes around the back with a big transaortic clamp and pushed it around the back, put one subcutaneously, and this patient who had a VVI pacer, who needed a transvenous ICD and who volunteered for this, which, by the way, ethically, I'll point out, at that time, New Zealand was the only country on earth that would say to their patients, you need an ICD, but we can't afford it. In Europe, they would lie and say, you don't need an ICD, and never tell them. In the US, it was considered unethical to do this kind of research because they needed the ICD, but they couldn't afford it. So part of the funding of the company was we paid for the ICD, transvenous ICD at the time, in exchange for doing an extra incision and doing some temporary work. Imagine doing that here at Duke. Imagine getting that through the IRB at Duke. Impossible. At that time, the physicians there, Warren Smith and Margaret Hood, told the patients straight up, all the patients signed up, no benefit except for the future. It's a very interesting ethical circumstance, but we bought for years $20,000 ICD therapy for these patients after they were told, not before, as an inducement. But the interesting part of this is we were all very, very nervous. We induced VF, not knowing what would happen, and our very first shock was 70 joules. We figured we could build a device that put out 100 joules. It would be huge, our thinking at the time. Very scary. Not only did the 70 work, we went all the way down to 25 joules. We were blown away that these two little subcutaneous electrodes, not in the heart, could defibrillate at such an incredibly low energy. And over the years, as we developed things, doing an enormous number of various trials, this summarizes a huge number of little trials, directional trials, getting us into the right space that led to 4 practical configurations. Obviously, we wanted to be up in the pectoral space, but it just didn't give you the same type of defibrillation as being laterally and having an electrode peristernally. And we didn't want to be on the other side of the sternum because that's a different tunneling and a more risky surgical procedure. So, and we looked at discs and we looked at leads and lead lengths and can positions. And we came up with the configuration that's in the clinical device. Lateral can, peristernal, 8-centimeter electrode, nice tight defibrillation thresholds. As I'll tell you, the can puts out 80 joules, 3 standard deviations above median defibrillation threshold, which tends to run around 34 over time. In this study, it was lower. If you looked, we did a study in 49 patients comparing the SICD to transvenous. It's about 3 times the defibrillation energy requirements, 36 joules in this 49 patient paired comparison. So why is it so low? It's really, it's amazing how low it is. And I commented about dermatology. Skin's an incredible protector. It's really amazing on how well it keeps stuff out of the body, not just rain, but electrons. It's really good. This, I've done finite element work. This is my concept of how current is flowing. And it's important, those of us that shock people think that we can visualize how those electrons are going through the thorax. I think that's fantasy. I think this is what's happening because of the empiric mapping we did over 8 years of how current's flowing. So here's the configuration. I believe we're right over the anterior RV and current goes in. Remember, the conductivity of blood is 5 times the conductivity of myocardial muscle. Very fast. And muscle is way above everything else in the chest. Also remember, the conductivity at high voltages is very different than conductivity at pacing voltages. Current can go and create its own conductivity when it's very high. It can improve its conductivity. My concept is the current goes into the RV, up to the RA, over to the LA through the very thin interatrial septum, down through the mitral valve, and out the apex to the can. And as we map the can location over the years, obviously if you get too close to the coil, you're going to just short or shunt. But if you try to go back to where you think makes sense, because your eyes say you're going right through the heart, in fact, your defibrillation requirements increase. So why is that? So this is kind of a speculative concept of why current may be going in that direction and going at such low energies for defibrillation. This is the first patient to get a device in New Zealand, kind of a classic scud heft patient, Carrie. You would agree? Class 2, good patient. 49-year-old, big guy. As you might think big versus small, no matter how big you are, when you strip away all that adipose, almost all our rib cages look the same. Santa's thin. I don't know, Galen's not as big a guy as he used to be, but his rib cage and Santa's rib cage aren't that different once you're under the skin. Big guys, a lot of Maoris we did, really big people, no problem in defibrillation. This is a photo of the team. That's John up in the back. You remember Warren Smith? And Margaret Hood was the operating EP. And Rick Sangara and Steve O'Connell were Cameron Health engineers. Fiona was Warren's nurse, and me. And this work, lots of people, but I just toss in Ricardo Capato, having done a lot of the animal work, and Andrew Grace, a lot of the human work out of Cambridge, Ricardo out of Milan. So what's the real why do all this? You know, you have transvenous devices that work. Yeah, they have some problems, but why do it? Well, I'm from Seattle. I left Duke as a Wolf Parkinson White guru. I go to Seattle. I clean out all the wolves in Washington State, Oregon, Idaho, Montana, and Alaska in 1.5 years. They're gone. Now what do I do? I'm at a university. I need to prove myself. Because I start seeing VF. You think VT is the problem of cardiac arrest. VT for me is a rare disease. VF is common. If I have my VF here, Gus, how long will it be before an AED gets on me?
I can run pretty fast down the hall. There's an AED, it's not for me.
All right, so we actually would time it in the ICU. The time from the onset of VF to PEA is 9 minutes. About that. It can be faster if you have class 3 heart failure, and maybe 14 minutes if you're a young person with, Brugada syndrome, but it's about 9 minutes. The reason you don't see VF here is because the Durham medic system is probably not that good. All right, in Seattle it's pretty good. We save 11% of VF people, which may not seem high, but that's huge compared to the general population, huge. So all I would see in the EP lab are VFers. They'd come in, you do your silly, ridiculous electrophysiology studies, and nothing made sense. You'd get nothing, or you'd see polymorphic this, you'd give drugs that make no sense. So over the years, we had really no recourse from research, if you were an arrhythmia person, other than VF. And it dawned on me way back then that the problem's VF, and it's in the middle sick population, the mild to moderate population, ergo scud heft, ergo HAT, the trials that we did. If you really want to attack the public health problem of cardiac arrest, you got to somehow deal with VF in people that you have no clue are going to have VF. We still don't have a big idea about that. The really sick people die with this stuff, and they need people like Chris to put in even more expensive machinery. So the barriers to indicated ICD therapy are really For me, I've always looked at devices as a public health solution, not as a toy, not as some engineering fantasy, but as a public health problem, because that's all I saw clinically in Seattle. Oh, the barriers are, as you know, the public, the press, and the regulators unbelievably negative towards hardware. There's something about titanium that instills hostility. It brings out the lawyers, right? Brings out the New York Times, the Barry Marins of the world, come out with great hostility. Why? It's psychologically strange. You wouldn't have that feeling towards beta blockers or ACE inhibitors, yet device therapy for the prevention of sudden death is every bit as well proven in certain studies, in certain populations, as those drugs. The perceived cost, I mean, what's a lifetime of Lipitor? It's much more expensive, as I'm sure you get to hear Dan Mark talk about economics all the time. I mean, he can make some of these drugs that we sprinkle on people like water look like millionaire drugs. So there are a lot of perceptions against an attack on a public health problem that affects 350,000 people a year. And of course, all the long-term consequences it leads. You have two really decent studies. They're good science. MATA-2, short-term and long-term, showing over 8 years survival benefit of ICD therapy, even when at the end of this trial, a lot of these people in the non-ICD curve crossed over. And the same with scud heft. Good statistics on MATA-2. Scud heft, as you well know, with Carrie. Thank you, Carrie, for this lovely analysis. Carrie and I put this slide together like the night before we presented at ACC, and the usual panic gust, not much different than today. All of you guys know this, you panic right before the presentation. Good study. I like this study. I'm real proud of it. We did a nice job. Why would you not put an ICD in a heart failure patient? A lot of people out there do not get ICD therapy because of the negative press, the regulations, all the negative perception. Here's the 12-year follow-up of scud heft that we have yet to put in the print. Even here, where 55% of the population crosses over on an intent to treat analysis, you still have a nice spread over 12 years. It's a good therapy, and it's hard to imagine not getting an ICD. Well, the reason is because people view all the transvenous problems and the over-complexity as too much of a burden on society. So let's go back to the subcutaneous ICD, talk about it a little bit, and give you some examples. So it puts out 80 joules, stores 100. It's 69 cc's. It's about twice the size of your transvenous devices. It's not that big. Most of the people in this room, you would not see it under their skin. ActiveCAN technology has some interesting coding to prevent polarization because the voltage is high. It has induction capabilities, does the usual self-checks, lasts for 5 years, shocks 100 times. It has post-shock pacing if you want. It's one lead, stores all the data. It does all the basic stuff, but the bells and whistles are all buried inside the technology, not exposed to you. It's put in with an incision here at the xiphoid, an incision here at the sternum-manubrial junction, and an incision in the anterior axillary line. Device is tucked between the anterior axillary line and the mid-axillary line on the 5th and 6th ribs. You don't need fluoro. It's all anatomically done. No fluoro. The lead gets put to just to the left of the midline. Easy to tunnel. If you're a good hands operator, it's 30 minutes skin to skin. every time. There are no surprises unless you're dealing with a dextrocardia or some weird cardiac anatomy. It's the same every time. Very simple procedure. The contraindications, there's only one absolute contraindication. The detection algorithm can't deal with unipolar pacer spikes. All other pacer spikes are okay if they're pre-existing. The indications for use, anything that the guidelines say are indications for ICDs, with the possible and likely exception, not absolute, but symptomatic bradycardia. And the reason I say not absolute is they can have a pacemaker and the SICD. Incessant VT, obviously a contraindication for any ICD. They should be ablated or drugged. And then people who have recurrent, reliably pace-terminatable VT, those people should probably be ablated as well, but they're a relative contraindication. Everybody else is FDA approved. So this is where the leads look and the can looks on everybody. On the lateral, it looks there. The leads anterior, right under the skin, typical location there. This is a post-CABG patient. I'm going to just scroll through a bunch of patients here. This is an engineer who sought us out in New Zealand, Christchurch, with Ian Crozier. This guy had a lead failure over here, or had an occluded access over here, had subclavian occlusion here, and had an RV lead inside, but couldn't get another transvenous device. His history is up there with prior VF, and he was a good candidate for an SICD. Kind of a typical case, actually. A lot of former transvenous patients now floating to the surface for the SICD in the US and in Europe. Here's a fellow that had VF storm, V-flutter storm while farming, got 8 shocks in the field with the device. Typical, we'll talk about the time, but this is a typical long time for detection and therapy. Ranges from a low of 12 up to a high of low mid-20s, which, as if you've been following this literature, you realize is a very good thing. Having hair triggers is no longer rational. Typical scars, this is at 1 month, shows what the can looks like. The xiphoid scar and the perimanubrial scar. A young man, here's another 30-day scar. This is a paper-thin chest. Actually, a 17-year-old guy, Luke Jourdan in Rotterdam, I actually did this procedure with Luke on Christmas Eve. And I didn't see the patient. Luke assured me the patient would be great. I walked into the operating room, and I made the incision here. That skin was like paper. But he's now 3 years out, no problems, no erosion. Really amazingly thin Dutch kid with Brugada. They had lots of Brugada at Rotterdam because of their genetic center. This used to be the youngest patient. Now we have a 30-pound 7-year-old. 10-year-old here with dilated cardiomyopathy. This patient's father was a pediatric cardiologist that sought the device out to avoid the lead problems long term. A lady with a RV outflow tract tumor. And just to show you, women can have problems on the bra line, and we've learned from Margaret Hood, who's put in a lot and has been concerned about that. You really never want to make incisions in the mammary crease for 2 reasons. One, on ladies, it's a problem because of the bra, but 2, it's just a bacteria-rich place. Infections, as we'll cover briefly, are the same as pectoral systems as long as you pay attention to things like that.
device may actually be in the way of that, and definitely is there a concern that the lead may get damaged when an mammogram is
Yeah,
being done?
it's a good point, Santa, and it's actually the opposite. If you look at where the pectoral can would be, you don't have the can sitting here. The incision is here because you need to have an anterior, otherwise you're going to have problems of accessing. The incision's here, but the can's sitting here, outside of the breast. And the bra line, you don't have the lead going through the breast. In fact, that's a no-no from a procedural point of view. It goes under the breast. So you're okay on that. And I believe we're going to see a report just on that very issue out of New Zealand. She was supposed to do that study. I don't know if she's ever done it. Another older woman showing the can. I thought I had a slide of an epicardial system here as well, but we've had devices in patients that had old epicardial ICDs. Just a brief comment about detection. Unlike, there's a couple of fundamental differences. The device is like our eyeballs. It looks at rhythms far field on the ECG, and it's a rhythm detector, not a beat detector. Transvenous systems are beat detectors, very different, and we'll explain in a moment. There are 3 orthogonal vectors that it looks at, and I use the term orthogonal because the can is around the sides, so you're really in a 3-dimensional structure for vectors. Tip electrode to proximal sense electrode, and then each of these guys to the can. If you're going to get an inappropriate shock, it's almost always the T wave that gets you, because you need a different filtering system. You're far field, you don't have the high frequency content that you do on a close bipolar lead. So the detection algorithm's challenge is amplitude overall and T wave rejection, and a little bit for big fat wide QRSs. Here's a comparison. The ECG from the SICD is like a V6 minus V1 or V6 minus V2 type of surface lead. This is the same patient demonstrating how you can easily get inappropriate detection. Different signal, far field. The transvenous ICD detects like this. It sees a signal, something, and then it goes into its analyzation mode, just boom, just like that. Now this may not seem really like a big deal, but it's huge from an innovation point of view. The SICD's first question is, am I in reality or not? Reality is very important. So the first thing it does is say, is this real or not? Is this a cardiac signal? Is it noise? Is it a make-break potential? Artifact of some sort? That's actually an enormous advance and done by a couple of the detection engineers at Cameron Health. And what that allows you to do is you can apply AC current right on the device, it won't detect. Very different type of system. Plus, it has multiple detection algorithms working simultaneously. The challenge of this is a very different detection system. It's more like an automated external defibrillator than an ICD. So there are multiple cross-checks occurring all the time, built upon a baseline template that's applied. And you can, I won't go into this because of time, but there's a screening tool that allows you to sort who's going to be a T-wave problem and who isn't beforehand. And this is just an image of that tool. In the FDA trial of 330 patients, this is therapy delivery, and comparing it to the known data at the time. The yellow is the SICD system. Same incidence of appropriate shocks, same incidence of inappropriate shocks. It's not better, but it's certainly not worse. Just a comment about tolerance of 80 joule shocks, and also a little bit of attention to this insanity that has swept through the US the last 10 years. Shocks kill. If shocks kill, why do we have these studies that were all done with shock-only devices save lives. It's a pretty peculiar concept when you think of it. It's fundamentally illogical. We also have the fact that in this system, if you do a transvenous coil, this is from Jolly up in Boston, you have a lot of voltage gradient right at the right ventricular endocardium and septum. So it gets very, very hot. With respect to subcutaneous systems, you have a more diffuse voltage gradient. It's not as hot. And as a consequence, and these are animal studies done by Ray Ideker, you don't have as high and as diverse a voltage gradient across the heart. So a subcutaneous system, even though it puts out 80 joules, a lot less goes across the heart, and it's more homogeneous. Whereas with epicardial and transvenous, you have these hot spots, and high energy hits the heart. And you see less cardiac injury with a subcutaneous device, almost no troponin elevation, whereas a transvenous system, you get big bumps in troponin. And the whole ATP thing is another thing that's a house of cards that's falling. First of all, in scud heft, most people over 4 years had no therapy. Those that did have therapy had it once, maybe twice. Very few people over the course of that time, this small number of people, 20%, had multiple episodes. So most people don't need a lot of device shocks or interventions. And then you have this finding from Art Moss, I didn't reference, just published in the New England Journal, called the Mated RIT study, showing that the more you intervene, the conventional programming of an ICD, the higher the inappropriate interventions. The longer you take and the more conservative your programming, the fewer the number of inappropriate interventions. And what is most shocking is that the death is less too. This is a big deal. The whole concept of painless ATP therapy may be a ruse that sent us down the wrong path for a long time. And in fact, if you look at the hazard ratios, A being the control standard, hair trigger programming of an ICD with a lot of ATP, B being high rate, and C being long duration, your hazard ratios for death and first inappropriate therapy are amazingly low. Amazing. With no real increase in syncope. Little trend, but nothing hot. So what's the impact of that? Oh, one more comment. Those of you that know the pain-free study, it's the only other randomized trial that looks at ATP. That study had a 42% increased mortality in the ATP arm, and it was stopped early, mostly to not get embarrassed. In the 330 patient 1-year follow-up mortality rate for the SICD trial that the FDA approved, notice something pretty unusual. The population of patients, I'll just show you, is the same as the general population. But take a look at the mortality rate. It's lower. Why is that? Is there something about the population that's lower risk? Maybe, not completely clear, but it's unlikely. It may be because there's no RV lead. There's no RV lead irritating the right ventricle. There's no RV lead pacing. There's no RV lead anti-tachycardia pacing. Maybe there's no tricuspid regurgitation. Maybe all that stuff, and certainly no pneumothorax, no hemothorax, no tamponade. Maybe it's that. I don't know. The only way we'll know for sure is a big clinical trial that I will not do. Somebody else will do. So let me close here as we get close to running out of time. Who's going to benefit and who may not benefit? Well, again, people with pre-existing unipolar pacers, no. You have to use judgment on these. The device has a lower limit of 170, so anybody with slow VT is out. The whole Brady pacing issue is questionable. Many people with pre-existing Brady pacers have SICDs, but whether you want to combine them or not, that's depends on the patient. And ATP issue is kind of dealer's choice at this point. So who's going to benefit? Well, the first person that benefits are the nurses. It's incredibly simple. As opposed to a transvenous ICD with 50 million, repeat, 50 million programmable options, you have 4 on this. First option, turn it on or off. Second option, do you want post-shock pacing? I don't, many do. SVT discrimination on or off? If I were redoing the device, I would remove that one and make it on all the time because it's a very good algorithm. And then the upper rate limit for shock only, or conditional shock, meaning no discrimination. High rate, shock everything. Very simple. The programmer is very small and very simple. So these are the indications that are approved. You know, the VF survivors, the made it 2 SCUD-HEF patients, lead fracture patients. There are a lot of lead fracture people or lead infected people are getting SICD. There are 2 million Americans with complex adult congenital heart disease, a new therapy for them. And then all the obvious people, you know, the Brugadas and the long QTs, et cetera. So I'll leave you with some takeaway points. Remember, you don't need fluoro, so you can have a sterile room and leave the EP lab for those young electrophysiologists that like to flog away at atrial fibrillation. Surgery is incredibly simple. Everybody in this room could do the surgery. It's as close to see one, do one, teach one as you get. Detection, very reasonable. Therapy, very reliable. Simple programming, and you've removed all the risks of transvenous leads forever. So I'll end with, it seems like a natural sequence of events. Increasing simplicity increases therapy adoption, and that's where I think we are with this. And I thank you.